Hi everyone, thanks for joining us. We're just going to give it another 2 minutes before we get started. Okay, just as we get ready to get started, we should get all panelists to get their video on. Annette and Monica, you can hold until we get to the Q&A session if you'd like. Okay, I think we can get started. Good morning, good afternoon, and good evening, everyone. My name is Naomi Berkshire. I'm the Executive Director of Harm Reduction International, and I'm really pleased to see everybody or be here today in the fourth webinar of our series on COVID and harm reduction. For this webinar, we're going to be focusing on housing, shelter, and survival. We've got an incredible lineup of speakers from around the world. This webinar series is a partnership that we've been running since the beginning of COVID, together with Input, Your Input, MDM, Médecins du Monde, UNODC, WHO, and Harm Reduction International. It's worth mentioning as we get started that the webinar will be recorded. So our format today, we'll be going through speakers from 4 different organizations around the world who give their perspectives and talk a little bit about the mechanisms they have in place around housing, shelter, and survival during COVID-19. After that, we'll move into more of a discussion format. I think it's been more interesting in the past to make sure we have time for questions from people dialing in, make sure we get extra insights from the speakers. So each of the speaker presentations will be about 5 minutes. We'll keep it quite short and sharp. After that, Matt Southwell from Your Input will be fielding questions from attendees. We'll get people to bring their personal perspective from their work or to ask questions of the panelists. And then finally, for that part of the Q&A session, we're lucky to have Annette Verster from the World Health Organization and Monica Chapagia from UNODC to chip in with institutional perspectives as relevant and as questions pertain to. If you have any questions, please put them in the chat box. You can start logging your questions as soon as they come up. And Matt and Suchitra Rajagopalan from Harm Reduction International and Samantha Hodgetts will be collecting those and getting ready for the Q&A session. Special thanks to Sam and Ernst Weiss from MDM for all their background conceptualizing and support with logistics. Kind of getting into the crux of it, this is a really important topic, and I'm glad we're making some time to grapple with it because I think it's going to be very much present in our discussions and in our everyday work for the foreseeable future. Under COVID, we've seen a surge of useful and constructive efforts dealing with shelter and homelessness. Some countries have made significant efforts to offer all people who are sleeping on the street access to accommodation in hotels and shelters. Usually these are for weeks at a time, so quite a significant step up. And then some countries, mostly high-income countries, we've seen some formal or de facto suspensions of evictions, which has also reduced some of the instability we're facing. These are short-term solutions, though, and I think that's on all of our minds. At the same time, COVID, as always, has shone a light on the inequalities and really demonstrated the limitations of the systems in which we work. You know, a lot of places around the world have really struggled with people on the street and poor people in trying to, implement COVID mitigation schemes and protect people. You know, the worst examples we've seen around the world are where people are housed or moved without their consent. There's some terrible footage from Cape Town in South Africa about people demonstrating they'd be moved to the edge of the city and kept there against their consent. All around Europe, I know that the closure of public toilets has had a big impact upon people who rely on that access to water and sanitation. And then even more broadly, you know, society's fixation on a permanent address has broader implications. In some societies, in order to access food aid from the government or shelter, you need an ID. And in order to have an ID, you need a permanent address. Equally, some of the COVID prison schemes have relied upon people to being able to demonstrate a permanent address if that person is to be eligible for release under the prison schemes. So again, it kind of circles around and around back to this idea of needing a permanent address. Now from me, our first speakers today are from Community Access in New York. Community Access is an organization which works to provide affordable housing to people with mental health needs. Community Access has buildings throughout the city and staff on site provide support services such as linking people to healthcare, offering supportive counselling, setting up transportation for people to get to appointments, working with people to ensure their benefits are correctly set up. Melissa Toonkel is the harm reduction specialist at Community Access. Her work centres on the people, not the drugs, and brings an innovative approach to harm reduction, including running a food and harm reduction group that introduces the principles of harm reduction, but through a nutrition and wellness lens. Also from Community Access, we have Alison Sutter, who's the Assistant Program Director. Through her career, Alison has worked on the health and rights of marginalised populations with a recurring theme of harm reduction, social justice, and mental health. She's worked both at international level and at city level prior to this with Urban Justice Centre and Open Society Foundations. So Melissa and Alison, take it away.
Thanks, Naomi. So I'll start by saying a few words more broadly about community access and our approach during COVID, and then I'll turn it over to Melissa to get more into the specifics of harm reduction and the support we do for our tenants who use drugs. So as Naomi said, we are a supportive housing program. So we operate about 20 apartment buildings throughout New York City that have a total of about 1,000 beds of supportive housing for people that are low income and have mental health needs, and we provide wraparound social and supportive services to our tenants. So we did start from a relatively strong place in some ways at the beginning of COVID because our tenants have access to stable housing and have that permanent address that is so important. But we focused at the beginning of this really on how we could help people shelter in place within that context. Many of our tenants lack access to income, access to food, so we wanted to bring as many resources in-house as we could to help people stay home. Also, many of our tenants have mental health needs, so at the beginning of the pandemic or throughout the pandemic, the anxiety and isolation we saw really exacerbating people's mental health concerns. We have tenants who spend a lot of their day out in the community as a coping mechanism, and as community resources shut down and their other healthcare providers, we saw that creating a lot of challenges for people. For example, people who hear voices, it can be extremely unbearable to stay at home all day in a small, silent apartment, or for our community members with history of trauma and anxiety, the news cycle and the changes to their environment were extremely stressful. We are a housing first program, so we are, what am I saying? For our tenants who use drugs, we were concerned about risks like using a loan and changes in use that might arise during a period of crisis. So our approach is really to try to pile on as many resources in-house as we could. We got cell phones into people's hands. We connected people to telehealth. We really focused on trying to help people manage their basic needs at home. We spent a lot of time checking in with people about what might make sheltering in place more bearable and bring those resources in-house. Access to food is a major concern, so we started doing grocery deliveries and free meals for our tenants to help them stay home and conserve their financial resources during the pandemic. So overall, I'd say that we were, trying to look at people's personal needs and their mental health and try to focus on getting resources into people's hands. An important thing was that as the U.S. started giving out guidance about take-home medication-assisted treatment, we saw that many of our tenants were not getting that take-home treatment and were still required to go into their clinics more frequently than necessary. So our harm reduction specialists did a lot of work around MAT advocacy on behalf of our tenants to help them get their treatment at home rather than having to keep going out in the community. Some great things that we saw emerge during COVID were, as we sort of tried to pile on these resources, we saw mutual aid networks arising within our community, people swapping resources. If one person got access to a certain food program, they might redistribute some of that food or swap other resources with neighbors. We have a lot of people that are older and really needed to stay home and not leave their apartments, and we saw neighbors looking out for each other in ways that we didn't expect that were quite amazing. So overall, I'd say that our approach was to pay attention to our community's mental health needs and personal needs and respond in a holistic way and adapt our services from there. So those are some more general notes. I'll turn over to Melissa to speak about our harm reduction specific services.
Hi, everybody. Basically, like what a harm reduction specialist at Community Access does is we focus on tenants in the building that have like drug use issues or like, I would say like severe mental health concerns, like more than average. Another thing that we do is, you know, like we have a lot of staff that are in our community at Community Access helping our tenants, and not a lot of them might know enough about like, you know, opioid overdoses and, you know, cocaine and things like that. So it's my job like to create trainings around that. I'm like certified in Narcan distribution, so I run like Narcan trainings for the staff and for the tenants. And we try to do, like Naomi had mentioned, like groups around harm reduction, whether it be for food or just recreation. Like another thing I would do is like take people to the movies because like it would reduce the stress. A lot of tenants don't have money for things like that. So basically that's my job, to try to help the tenants with harm reduction that use drugs and mental health, but like also the staff that might struggle engaging with the tenants around these difficult topics. So a lot has changed like during COVID, especially since like I opted to spend a lot of time more at home since I don't live very close to the building. So we like our documentation is very strict in New York with distributing of Narcan post-COVID. So we would have to fill out certain forms, do like monthly reporting. They've relaxed that a bit where like now we don't have to do the forms for each Narcan kit. We've been able to train people over the phone. I actually did training for our newest service coordinator yesterday over the phone. I also like with supply distribution, we would have to track it very like strictly. At this point, there's not a lot of people in the main office. Like we used to do once every few months, like gather together and build these safer use kits. Like we have a safe smoking kit for people that use crack. We have a safe injection kit. We don't distribute needles, but it's like the basics to, you know, help people shoot up properly. And all of these supplies would be distributed, and it was like very strict guidelines on how we would have to make sure that it was documented that we were passing these things out, and like trainings for staff. And it was lucky that because our agency is so diligent with like passing around this idea of harm reduction to all its staff, like as opposed to just the harm reduction specialist, that when COVID did kick in, a lot of our staff were already like capable of, you know, distributing these supplies, and they were able to have these conversations with tenants in my absence from working from home. So that was really important. We also have a partnership with an agency called Washington Heights Corner Project. They used to come by the building post-COVID every 2 weeks and do holistic services like sound therapy, acupuncture, and distribute safe use supplies. They would do HIV testing. They were unable to come out during COVID. And so now I've been connecting with the person, Juan. He goes out, he's amazing. He goes out to like all these buildings and drops off supplies. And then I'll give him the tenant's phone number with their permission. And then he'll outreach them because he also has to document, like, you know, he can't just drop off a bag of supplies and then not like interact with the tenants. So he's been doing that. He's been making like holistic care packages for certain tenants that maybe don't use drugs, but like enjoy the services that he had provided previously. So that's different. And one of the bigger things that I've really focused on while working at home and talking to people over the phone is in the US, we were granted stimulus checks for that period of time when like everybody was out of work and everything was going haywire. And we were actually like everybody, even like SSI recipients were given and disability and veterans were given this $1,200 free from the government. And I was very concerned. A lot of our other buildings and teams were very concerned about, you know, tenants that are not used to having so much money all at once. Sorry, that's my cats. And you know, like how they would react to having $1,200 in their hands and then trying to like spend it all at one time. I was very worried about some of my tenants with like overdosing and like the fact of isolation and like using a loan. So I had some very well thought out conversations about how to help them budget that money. We offer payee services with our entitlements department. So we were actually able to like talk to the tenants about how, like if they wanted to have it like dispersed without like not getting it all at once, like dispersing it in increments. I actually had one tenant who like always wanted a computer and he tends to like spend all his money on using crack. So I was able to have like several conversations with him about purchasing this computer for himself. We worked it out with the entitlements department. They purchased the computer for him. And then, you know, he also realized that like, yeah, I'm not used to smoking so much crack all at once. You know, he only gets like $100 a week regularly. So he was concerned as well after like our numerous conversations. And we were able to like have the entitlements department like disperse his checks in $100 increments, like on a weekly basis. So now he has his computer and he's getting, you know, about an additional $100 a week. So just those are just some of the things. I guess like I could talk for hours about this stuff, but I don't want to take up so much time. But yeah, like harm reduction has changed a lot in COVID. But I think that in the end of the day, like the Housing First initiative that Community Access brings to the table is like the ultimate form of harm reduction, because like Naomi said, and also Allison, you know, said, is that like if our tenants didn't have a place to live, I think that it would have been so much worse. And so it's just really, I'm really grateful that I, you know, we're able to like work in a place that, you know, allows our people to be safe, and we were able to like work around those other barriers. So it could have been worse, I think.
Amazing. Thank you so much, Mel and Alison. It makes me smile just learning about the extent to which you really are about the whole person. And my mind is blown by the phone naloxone training. I haven't heard about that before, so that's really awesome. Our next speaker is Chris Abor, who is the founder and executive director at Vocal Kenya. Vocal stands for Voices of Community Action and Leadership. Throughout his career, Chris has worked to address inequality and power struggles in society, from the high-density informal settlements in Nairobi to regional and international spaces. Over the past few months, Vocal has mobilized super quickly and been particularly focused on harm reduction service delivery and COVID protection for people living in the informal areas of Nairobi, Kibera, and Kawangware. I said that wrong, Chris. Over to you.
Thank you, Naomi. Vocal is a health and rights NGO. our work is basically focused on ending prohibition and punitive drug control laws and policies, just to make sure that every Kenyan citizen has access to health and healthcare. I mean, as a right and not as a privilege, because it's in the Constitution, and it's also it's also a human right from all the perspectives. So we do national and local policy advocacy to make sure that members of parliament, especially parliamentary health committees, when they're making laws or pieces of legislation, then they take into account the vulnerability that is dominant in communities of people who use drugs. We also work with members of the county government, especially the health management teams, to make sure that policies and conversations that they have on health is central to survival and existence of people who use drugs, who are marginalized and who are criminalized in Kenya. To jump into what we do or what is happening in Kenya with regards to COVID-19. As at now, Kenya has about 4,000 confirmed cases of people who are living now with COVID-19. And the infamous guidelines: wash your hands with soap, use a hand sanitizer, work from home, maintain social distance. I mean, all these are another world altogether when you come to informal settlement. You know, in this informal settlement, access to water and sanitation, and even solid waste services, I mean, is just a story. You know, and if you tell them about keeping distance, all these are luxury, and they take it like those are people who live in estates who would keep distance or work from home. You know, so a vocal has designed a program to make sure that communities in formal settlements have proper access to health services, especially those people who are injecting drugs. Towards this end, Vocal has put together hand washing stations that are strategically put in places where people inject drugs, where people who use drugs spend their time, where they go to tell stories and so on and so forth. So we've put hand washing stations with water and soap, and we've also put up posters with the guidelines issued by World Health Organization and Ministry of Health that we've translated into local language and went further to translate it into slang, you know, the street language that people who use drugs can easily associate with. We've gone further to ask some of them to produce some small videos, their faces, that they can use to educate people when they come to wash their hands. So our hand washing stations are information and communication centers within the places where people use drugs. And we feel that kind of strategy will further support us in terms of making sure that people who use drugs and who are already vulnerable and criminalized do not again contact the coronavirus. So here, basically, the overall focus is to make sure that hygiene promotion campaigns are creatively and local. They are creatively and locally delivered to people who use drugs where they are. We've also designed a strategy to facilitate access to HIV and harm reduction services in the context of the COVID-19. What we've done is that we've organized a peer-led community health volunteer strategy, where people who use drugs have been trained on community health service delivery. So since they live in the slums and they know people use drugs in the slums as their peers, so those who are on OST, those who are living with HIV, or those who have other complications, including complications associated with COVID-19, can get help. And what they do is that they walk around and they speak to these people and they collect data. And if there's need, they communicate that to our center, where we have a government number that we call, and these people are linked to support on issues of COVID-19. And we also make sure that these people, if they are on antiretroviral treatment, they get their refill of ARVs. So we have community health volunteers who are dedicated to make sure that community members already have access to services that they need, even when there's lockdown in Nairobi, in Mombasa, and other cities in Kenya where we have lockdown. So for us as Vocal, we want to make sure that service delivery continues, and we want to make sure that advocacy for expanding space for harm reduction services exist. Thank you.
Thank you so much, Chris. I think in terms of the words that stick in my head, your phrase that keeping distance is a luxury, I think captures a lot of that, and is really important. Our next speaker is Ryan Kwabari. Ryan is the chairperson of Arus Pelangi, the Indonesian Federation of Lesbian, Gay, Bisexual, Transgender, Transsexual, and Intersex Community. Arus Pelangi was established in 2006 as a response to a desperate need in Indonesia for formal legal representation of the LGBT community in order to affect the societal norms and perceptions and increase the overall awareness of the rights of the LGBT community. And even before Arus Pelangi, I did some internet stalking this morning. Ryan has dedicated his career to the health and rights of marginalized groups. So I feel really privileged to have Ryan join us today, and I think it's a really important moment for us to be sharing and learning, you know, between different communities, not just sitting in our harm reduction sector, and acknowledge the great deal of respect I think we all have for the mobilisation and advocacy gains the LGBTQIA community has achieved in recent years. So thank you so much for joining us, Ryan.
Thank you so much. So I have a presentations to like strategizing what I'm talking, because I have so much information to deliver, but so much little time. So yeah. Okay. So thank you so much for the opportunity to talk here about the impact of the COVID-19 pandemics. And I'm talking on behalf of the CRM coalitions, which Arus Pelangi is a part of it. So what is CRM? CRM is crisis response mechanism coalitions that focus on prevention and management of crisis situations toward LGBTIQ people in Indonesia. This is of 5 national organizations, including Arus Pelangi, of LGBTIQ organization and legal aid institution. COVID-19 pandemic in Indonesia. What's wrong with that? Since the first COVID-19 case has been announced in 2 March of 2020 in Indonesia, the cases significantly increased throughout this month. Now there are 762 cases, the 30 rankings from the world, and the Indonesian government is quite ignorant in terms of handling the pandemics. They come up with the idea of herd immunity without preparing comprehensive health facility and enabling environment during the pandemic. The government more focused on how we can growing the economy back rather than protecting and handling the pandemic situations. No effective institutional support from the governments, and the government start to force us to do like civil to civil support, which quite dangerous for marginalized people because of the civil society movement. So we are focused on, that's why we are focused on the more marginalized people like transgender women community. Why transgender women most affected? Most of transgender women in Indonesia works in the street as street singers, sex workers, and then the physical distancing caused the majority of transgender women losing their incomes. it's like we have a government program called large scale physical distancing since the mid of the March, and it's been locked down since then. And then the transgender women who works in the city is like having no job at all after that. In the first week of lockdown in March, there are 640 trans women in Jakarta sub-region lost their income and cannot cover their daily basic needs, food, sanitary, something like that, and no access for the government support because most of trans women has no ID cards, and there is a lot of stigma and discriminations along transgender women in Indonesia. So it's like push aside them to getting a more support from the government. And then because of the transgender women living in uh, slum area, they are more vulnerable to COVID-19 transmission. So we decided to make donations. This is our posters. This is more like a fast response. So we started in Jakarta as a capital city. From the very rapid assessments that we've done with the number of 640 transgender women, and after that we gradually increase our distributions into other cities in Indonesia. The distributions. Tanggal Suara as a trans women organizations in Jakarta and part of the CRM committee open hotlines and approach a trans women focal points in every districts and provinces, started from Jakarta area. After that, they make a need assessment by phones, what they need, how many days can we support them, something like that. And we distribute the money to the focal point based on the community needs. And after that, the focal point took the money to buy groceries and distribute to the community. Yeah, and then we also launch regular public reports to publish our beneficiaries of the donations. We started from Jakarta, and now we distribute the donations into uh, some provinces in Indonesia, because Indonesia is quite large country. So yeah, it's hard to distributing the money and the basic needs. So, and then we are trying. And then the challenges, because of the lockdown situations, and now we have a phase in Indonesia called the new normal. It's like the 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 trial of the herd immunity situation in Indonesia. So they are stop the lockdowns and more like to have a regular activities, but the situations remain the same. And then the needs also expanded because it's more than 1 month. The needs is growing up. It's like they also now needs uh, the the renting payments and the tuition payments that uh, we have to look forward for that. And also the challenge is also the sustainability, because yeah, it's basically a donation. So it might be stop one day, then and then the needs is still there. So yeah, it's still hard to us to having a strategy about the sustainability. I think that's all from me. I hope it's clear, and thank you very much.
It's very clear. Thank you so much, Ryan. This is incredible on so many levels, and I'm full of admiration for how quickly you were able to, monitor and see the issue of trans women not being able to work, and then mount a response. I'd be super interested in hearing a little bit more about your hotline, because it's something that Chris and I have talked about in the past. How did you set up the hotline?
So we set up a cell phones that that used for a hotline so people can reach them, especially the transgender community, because they are living communally, so we can distribute the numbers and they can contact us, something like that.
And so it just one person to take responsibility for that phone and for answering it.
Yes, unfortunately. Yeah.
Chris, you know how we were talking about using a hotline for your COVID response? Is this more or less in line with how you're playing it out? Getting people to dial in?
Yes, because we had tried the option of having a toll-free number, but then because of issues of criminalization and trust, people are not able to call that. So when we gave out that, they preferred calling me from my cell phone. So we got a cell phone and a local number and stationed it in the office. Then someone had to sit and man it. Yeah.
Okay, very interesting. But I digress because we have one final fabulous speaker. Let me find my page. So sorry about the delay. Our final speaker today is Marios Atzemis. Marios is a sociologist and a writer and a leader of the community of people who use drugs. Marios has served as the harm reduction officer at the Greek Association of People Living with HIV, Positive Voice, for a number of years now, but also has a lot of leadership positions across the region. A steering committee member of AIDS Action Europe, a member of the European AIDS Treatment Action Group, and on the board of directors of Drug Policy Network Southeast Europe. Now, Marios is based in Athens, and there's been some quite significant wins in our COVID response efforts. So I'm super excited to hear about how you move that forward, Marios. Please take it away.
All right, thank you for this introduction. Always a pleasure working with you. Thanks for this invitation. Also, I have to say that because I heard with attention the previous speakers, there are so many similarities with Greece in many levels, and it's not a surprise for me because all our communities are directly affected from the pandemic and also from racism and negative stereotypes. So more or less it's the same, and more or less we are on the same page. Now, our main topic today is like the shelter of homeless drug users who was actually opened during the Greek Orthodox Easter, like 2 months before, exactly 2 months before, in the center of Athens, and actually in one of the most, let's say, old open drug scenes in the center of Athens. So it has a capacity of 140 beds, but now it's around 80 people inside there. It's the most vulnerable of our community. And the one question that has been raised is how the pandemic actually was a catalyst for that. The answer is yes. There was, let's say, an integrated public health project towards the pandemic. And one secret part of the project was to open this kind of a shelter so the homeless drug users could be concentrated, tested for COVID-19, and also being kind of protected for many, things like the police brutality. The police has been very, very aggressive since we have a new conservative government, not only with drug users, but with migrant refugees, the Roma population, all what they perceive as something inferior and as something that is a threat to their normality. Now, there's been a lot of work. There's been a lot of work with all of our colleagues for advocating for this shelter. I'm talking about like really countless hours we have spent talking with the previous mayor and his board of directors. We also met in the Embassy of Holland with the mayor of Amsterdam and the ambassador of Holland, who had a very good integrated plan, a project for this shelter, who was finally rejected from the previous mayor. So there has been a lot of work and a lot of advocacy before. It wasn't a kind of surprise. The surprise was that all the bureaucratic obstacles and the barriers, who I thought it was a fate that we cannot escape of it, they were literally smashed within minutes with the new mayor. And I have to say that the new mayor belongs to the Conservative Party. And also this kind of a project, it's a project of a kind of a new gentrification of the center of Athens. But the result counts. And the result is that we have this kind of a shelter now for people who were like two months before, they couldn't even have access to water during the pandemic or to food. And also because before the lockdown, it was the crowd around them, what I call the mantle of the crowd around the drug users. After the lockdown, they were very visible, and in the streets there were only the drug users and the police. And you can imagine the result of that. So the shelter is a shelter literally for survival, for the survival of these people. Now, it is a collaboration between two treatment programs we have in Greece that they dominate ideologically the field, and usually they fight with each other. So it is Okana, which holds the monopoly of the opioid substitution treatment, and Kethea, which is a traditionally, let's say, substance-free, tough love program. I visited the shelter, and that was expressed, this kind of rivalry between them. It was expressed from the colleagues I met from both the programs there. But I don't think that does not affect actually the people who are inside. Let's say something final, because I saw the notice that I'm over 5 minutes, which is not something new for me. You can stop me because I can speak for hours. But I have to say something. We have a transition from the central government, who took the decisions about everything in the drug field, now to a more municipality level. The mayor of Athens, these two treatments are responsible for this shelter, and also we are working with them. We are doing HIV and hepatitis tests inside. And this is something new, because this is a way for many other interventions. The mayor and the municipality now, they will start an initiative for naloxone and also for mobile drug consumption facilities. If you have any question, I'll be happy to answer. I'll stop here. And very happy to share with you all this information.
Thank you so much, Marios. I think there will be a lot of questions for you. This is a substantial step forward to have 140 beds specifically for people, men and women who use drugs. I think what you said is around the hypervisibility of street-based people who use drugs during the initial days of COVID is something that kind of rings true around the world. I think as we look at governments trying to respond appropriately to protect public health and seeing the police as a vehicle for that, it's having quite disastrous consequences, including excessive force and brutality. Obviously, we see that with the protests around the world with Black Lives Matter as well. It all kind of comes, in a cluster together around social justice issues and those who are oppressed. But I will not rant. I will hand over to Matt Southwell, who will take us through a few of the questions coming in.
Great, thank you everybody for a really excellent range of speeches, a very interesting and discussion. So we've got some questions coming in from the audience. So Mietsu Pro, I think this is Pakistan, is this someone from Pakistan who's making a comment about LGBT people and managing some of the social stigma issues around that? Can we bring them on? Is that possible? Okay, while we're working that one out, actually, I know, so we've got some questions here. There's an anonymous attendee who's asking some questions. So let me just read those questions out because they're not really able to connect. So Melissa, you were stressing how the key Housing First programs are, how key the Housing First programs are in reducing harms. Thinking about the post-COVID phase and the fact that many may lose income and houses, what are the key barriers to establishing and implementing more of these programs? You'll need to come off mute.
I mean, I guess I'm not, like one to speak about, creating more housing first programs. I'm just a little harm reduction person. But honestly, what I've come to notice in other agencies and through my own life experiences, that in New York City in particular and upstate New York, a lot of the programs are requiring people to not use drugs to be able to get into these programs. They require, so like a person might be homeless, let's say in New York City, and they want to get into this program to like better themselves. They need, but it's kind of hard if I have to go to an appointment and I'm sleeping on the street and I can't take a shower. Excuse me, I'm sorry. And so they might deny this person the services they need because they're going to put up this stipulation that they have to be drug-free first and, before they can access these services. And this is very real, and this is still going on today. So one of the unique things about community access is just that we don't require anything. We're like, come as you are. If you use drugs, that's fine. Like, so the Housing First initiative is basically saying that like, you can come as you are, and then once you get here, we'll reduce the harm of your homelessness. We'll take you off the street, give you an apartment, help you build yourself up from there. And then, later after you've settled in and things are better, then we can begin to work on, substance use or mental health concerns. There's no requirement for people to live in our buildings and get treatment of any sort. I mean, there's plenty of tenants that I work with that have mental health issues. They hear voices and they choose not to see a psychiatrist. They choose not to take medication. And we're not there to force them to do that. But it's a very real thing that many of the New York City programs are abstinence-based, and they will force medication on people. So I guess to answer your question is like, we kind of need like more Housing First initiatives where we're stopping these stipulations so we can just get more people housed. I mean, the reality of is that like, if I'm living on the street, it's a lot easier to get through the freezing cold night in New York City if I'm drunk and high than if I'm sober, So, I mean, it's unrealistic to expect these stipulations from people. So, I mean, I don't, I guess, like, again, to answer the question is, like, these programs need to, like, lower their threshold for acceptance, and we would have a lot more people housed.
Thank you very much for that. So I think we're looking at this really fundamental issue that housing is harm reduction, that if you don't have a house, everything else is very limited in your opportunities, but it also shouldn't be conditional, that people shouldn't be imposed into treatment in order to access housing. Do other people have comments about this, really sort of the fundamentals of harm reduction and how we ensure access for people who are most vulnerable and most excluded?
Actually, I want to say something, Matt, if I may. Food, access to food was in some places an issue that was actually more pressing than access to services, because, for instance, in Bangladesh, there is a government program that allows people to get access to rice and some food every day. But many of the people who were using drugs and were clients of the harm reduction services didn't have the proper documents, so they were excluded. And then, you know, there was a lot of advocacy in place and trying to find a solution for these people to have access to food, because their first and priority was not dying of starvation, and then have access to services. So as you said before, ensuring access to the basics, to the food and the roof above the head is sometimes more important, and is the first step in, you know, people finding a balance and looking for HIV services or other kind of treatment if they want to.
Great, and I think we've seen this around HIV as well, that the fundamental of providing food. You know, do we give people ART medications, but then they don't have any food to eat alongside those medications? Annette, do you have sort of comments on that sort of interaction between health, housing and food in that way?
Thank you, Matt, and thank you to all the speakers for really interesting presentations. It's really good. I mean, you heard this is the fourth seminar in the series, and there's another series with also already 4 webinars, and it's really interesting to hear also these broadening issues, not only around other populations such as transgender women in this case, but also to go back to these fundamental issues, which in a way I think we need to unpack what is COVID related here, because that was the real reason for these webinars. But of course, a lot of our work and a lot of the issues related to vulnerability is directly linked to that. So unpacking housing or from the current situation and the general situation where a lot of people do not have access to that. And I think what, was it Chris who said, you know, things like hand washing and having access to sanitation and social or physical distancing is a luxury. And I guess the same goes for housing and nutrition, which for many of the people we're talking about is a luxury. And these luxuries have become even more challenged in current times. So I'm trying to see, because we have on the one hand situations like, I think South Africa was mentioned earlier, where people went on the street because they didn't have food, and there was people who used drugs, but everybody, other people living in vulnerable positions, but also people being rounded up because they were visible on the streets, as was mentioned earlier, and were rounded up and put in well, I don't know even if it was a shelter, but in stadiums and situations like that. So that is related to COVID, whereas generally, to go back to your question, Matt, these issues are critical and often catch-22 situations where, because you don't have an ID, you can't get access to healthcare and health services, and you can't get access to housing. So I think the examples that have been presented today have been really interesting. And I was wondering also about the, and it was one of the questions as well, around this donation program, which, I mean, we're talking about the role of the government, and we're talking about private initiatives here of civil society and how these interact. And I think that is one of the key areas that we probably come back to when you ask me about what are the fundamentals, that what are the responsibility, what is the government's responsibility, what can other people and other organizations do and contribute to, that is also very critical in this discussion.
Thank you very much, Annette. Yeah, I think it's very interesting. We're seeing this on some levels, some countries responding and saying, this is a time to embrace homeless people and draw people in and respond with this sort of very engaging way of seeing us as a community. And other countries seem to be responding in a highly punitive way, driving, very harsh police actions. And I know that's been particularly the case in Athens. Marius, do you want to sort of comment on how that's been in terms of this much more sort of challenging environment from the mayor of Athens and the problems that drug users have been receiving on the ground? You need to come off mute.
Yeah. Okay. Finally, yes. Yeah. Matt, it's a very good question. It's a kind of a contradictory, condition, because on the one hand, they say that they want to protect, let's say, the area around the shelter, okay, and which is still a very traditional open drug scene, okay. And on the other hand, there are, dozens of cops around harassing the people from the shelter. I also know that they arrested some guys from the shelter like 1 week before, so they had also the opportunity to enter to the room and to get some, some kind of quantity of illegal substances. And they started threatening people who work in the shelter that we're gonna close it down. And then the mayor probably told them, to relax. And they said, we apologize. And the next day they do the same. So it's a kind of a constant bullying of our community. On the one hand from the police, on the other hand, they say, oh, we are protecting the shelter. And this goes all around Athens. It's a kind of, let's say, chaotic condition. A friend of mine who is a very active, heroin user on the street, he told me that the whole condition reminds him the Pac-Man game, that, the users are running around the blocks trying to avoid the little ghosts, who the little ghosts are the cops. And the cops actually working, to a more violent gentrification project. They are pushing people from the center to the outskirts of Athens, so they can actually remodel the center of Athens for the tourists. It's something you can see with the naked eye now. And I think that's a more integrated project, and we see just some little things of that. But on the other hand, just to say that, on the other hand, because I don't want to sound negative, the shelter helps a lot of people, people who did not have to eat and to sleep. Now they have.
So look, I think this is the contrariness that we're facing. I'm seeing a question coming in from Tasleem. Tasleem, would you like to ask a question from Pakistan?
Hello, can you listen?
Yes, we can hear you, Tasleem.
Yes, I'm Tasleem Akhtar from Pakistan. I'm working as a clinical psychologist. I'm international certified addiction professional. I kept 2 levels, and I'm a national trainer by UNODC. I'm running a trust hospital in Pakistan, where we are providing services free of cost for the patients for the mental health since last 10 years. So in pandemic condition, my institute is helping the people we are providing foods, free of cost treatment, online services as well. And so many people in Pakistan are doing like me in the Pakistan, but still since 24 May, health conditions are getting worse. So many deaths rates increasing on the daily basis here in Pakistan. Public and government are trying to doing what they can do, but situation is getting worse. So my question is how your platform can help my public or my government to reduce or help or guide us where we are making mistakes, or how we can increase the health or safety in our Pakistan.
Thank you very much. So maybe Monica, do you want to talk about the guidance that UNODC produced with some civil society partners early on to guide people? And then if others have comments, please feel free to jump in.
Yes, sure. I mean, it's we together with UNODC, together with WHO and Input and Harm Reduction International, and also other partners, we developed from the early days. I mean, early days for the rest of the world, actually, in March. Guidance on maintaining the continuity and the sustainability of harm reduction programs, and they are translated in all the language. I know that my colleague in Pakistan translated and adapted them and put it on the website. They are available on our main website, and also I hope in the local website as well. There is also guidance about the continuity of treatment programs if people are interested in this as well. So all these are available, and of course, if you will need more support in implementing these recommendations, we will be very happy to provide.
Could we see if, Rui, do you want to ask a question?
Hi all, hi Mats.
Hi, Rui.
Nice job with this series of webinar on COVID. I'd like to put this reflection or these thoughts on the normal that we had before produced this kind of situation, and this kind of non-sustainable world that produces lots of people that are considered subhuman. And now that this is so very well revealed and everyone could see this, and I mean, how can Europe be what Europe says wants to be? How can how can Europe be kind of a lighthouse for a new normal where we don't dehumanize the other, where people don't come together finding their own reflections, like love one another and not one-to-one the same? How can we love diversity? How can we bring together a new kind of I mean, alignment, or well, this is it, my friends.
Thank you very much, Rui. So I think we've seen this real shift in terms of practice and engaging marginalized populations, which ranges from incredibly progressive and innovative through to quite challenging and problematic. We have this opportunity to create a new normal, to think about what the world should be like and what we would like the world to be like post COVID-19, or at least post the lockdown. Let me ask each of the panelists, if you could pick one thing that you would like to see as part of the new normal, what would it be? Can I get, do you want me to pick, do you mind if I pick on people? I'm just going to do it in the order you appear on my screen. So Alison, do you fancy having a go at that first? And then Ryan, you're next.
I mean, there's a lot of things that are coming to mind. I think one thing in the U.S. context is access to universal health care would be a huge change that we'd like to see. We've seen a lot of calls for that during COVID, and sort of COVID-specific health care to be subsidized and covered, but expanding that, I think, would help us get on track for a more positive shift in the future.
Right. So this has been a real test of the strength of different healthcare systems around the world. Ryan, if you could change something about the new normal, what would it be?
Yeah, this is a hard question though. Yeah, because of the situations that happens now, I perceive new normal as quite in a negative terms. But if if I if we can change some things, it would be access to everyone. It's a universal access for everyone. Yeah, I think that's
Great.
all.
And I think one of the things you've demonstrated through your work, Ryan, is that you have to
Yeah,
really go to make the effort to make healthcare accessible to everyone. It's not just about saying healthcare is here, you can access it. It's about actually proactively, as you've done with the trans community, going out and reaching people with healthcare. So, you know, really, I'm very impressed by your work. Thank you. Mario,
exactly.
would you
Thank
like
you.
to give a comment? And Melissa, I'm coming to you next.
Yes, Matt, this is a very good question. Actually, two things came to my mind very quick. The one is that we have to stop. I'm talking about the Southern Europe, actually, have to stop the abolition of what is left from the welfare state. And we have to fight poverty because there is an ongoing economic crisis, and the vulnerable become rapidly much more vulnerable. And we are a community that it's very vulnerable to that. The second is finally the meaningful involvement and embodiment of our community of people who use drugs in everything that affects our lives, in projects, in policies, in everything. Nothing for us without us. You know, this is the slogan. That's it.
Thank you. And it's not just a nice, it's not a nicety to involve people, it's how you find out what the community wants and how you tailor your responses and how you bring the community into your responses. Thank you so much, Marios. Melissa, and then coming to you, Monica, next.
I think that like one of the things that I would like to keep in like the new normal would be like I mean, the way that like they distributed like supplies and money to people. Like, for example, like I live in the South Bronx, which is like a very poor neighborhood in New York City. And there were many students in schools that were struggling to get electronic devices, to stay on task. And it seems like through COVID, they were able to give everybody iPads. That schools have been handing out food to everybody in the community. So I think that like that outreach to like the you know the lesser people per se, like in these minority communities that are a lot of times overlooked, really got like a chance to get things that were like much needed. And I mean, it's just sad that it took a pandemic for us to be able to get these resources, but I wish that like we could target these minority communities more often and continue to provide these resources long after COVID is gone.
Yeah, it's remarkable what is possible when a crisis hits, and it does make you ask, why did we have to wait for a crisis for so many of the positive gains that we've secured? So Monica, and then coming to Annette afterwards.
Well, Matt, I think you know my answer. So I think what come out as strangely a good outcome was that treatment was where was available, treatment was made more accessible, meaning that, for instance, for opioid substitution therapy, you know, years and years of advocacy for giving take-home doses and checking the eligibility of the clients and trusting them, and you know, making the treatment more welcoming, the treatment centers more welcoming and accessible. No, didn't give that many results, but 1 month into the pandemic, we heard from more and more countries that they were implementing take-home doses starting from 2 weeks to even 6 weeks or more. So I think that was something that was you know, the entire harm reduction community was long fighting for, and it was achieved in some places, not everywhere. And I know that it comes with the cost, with people not being able to enter the treatment because of the certain restrictions with all sorts of limitation. But however, countries that put in place take-home doses seem to be satisfied with the results. The community seems to be also happy with the results. So for those who have access to take-home doses, I think it's a huge game, and I hope this will stay in place. And actually, we will try to keep this in place, because we are looking into documenting what happened in the country. We'll work together with WHO and with Harm Reduction International and with Input and others who are looking into this to see, you know, what exactly happened and what are the lessons learned that can be applied in the future to maintain what was achieved and expand.
Thank you very much. Absolutely critical. I mean, we have this amazing changes around OST, and drug users have responded all around the world by showing ourselves to be highly responsible when we're given the chance to manage our dose and manage our own treatment, rather than being infantilized all the time. So Annette, let me pass to you as the last person on this question.
Yeah, that's always an easy one. After all the good comments that have been made, maybe I should just take it from the perspective of the World Health Organization, where I work. And I think it was Melissa who mentioned universal health coverage. One of the key areas or focus of the work of the organization for the next decade is it's called the 3 billions. And one of the billions is to make sure that 1 billion more people have access to health. And I think, because also want to make the link on the topic of this specific webinar, that of course that is completely linked with social justice, with acceptance of behaviors, acceptance of the fact that some people use drugs, that there are LGBTIQ, and that there's sex work, and that people are in prisons, and that everybody should be able to have access to essential health services. And in addition to social justice and acceptance of people, and seeing people as they are, and looking at it from a person-centered perspective, I think poverty is also something that was mentioned earlier, and that brings us back again to the issue of housing and other essential areas as nutrition and the other things we mentioned. Also the meaningful involvement. I think we cannot get anywhere if we do not bring in the people that we want to reach, or that we want to make our services available to. So I think everybody has mentioned some aspects, and the new normal would definitely be, to summarize by this, social justice, acceptance, access for everybody for the key issues in life.
Thank you. That's a really lovely summary, which I won't try to better. Let me pass to Chris just to make a final comment. So Chris has just switched to audio because he's got a bit of an unstable connection. Chris, would you like to make a last comment on this, on what you would like to see in the new normal? And just before you do that, apologies, Kennedy, that we weren't able to get you in Zambia. Lovely to see you on the call, and apologies for running out of time. So Chris, please do tell us what you'd like to see in the new normal.
Thank you very much, Matt. For me, I think most of us were in this side of the world with very unstable healthcare system. We need to push more so that people use drugs, community of people use drugs are included. We have to push more to make sure that all legislation, all conversations that touch on livelihoods and life of human being in Kenya, people use drugs at the center of it. We have to push more to make sure that the leadership and the movement of people who use drugs is built and supported. We have to push more to make sure that harm reduction is at the core of the human rights conversation in Kenya. That's mine, and to make sure that the services reach people where they are. Thank you, Matt.
Great, thanks. And I've been watching with great amount of being very impressed by the very practical response I've seen in Kenya, with people putting hand washing stations in, even where people don't have homes, but we can still in the homeless camps allow people to have facilities to wash their hands and to do the best they can in restricted circumstances. So thank you all very much for your comments. I'm going to pass back to Naomi, who will provide some summary and wrapping up.
Thank you so much, Matt. World best facilitator, I think. And to all our panelists, thank you for the incredible examples of responses, from the short-term pragmatic ones to the more medium to long-term ones, which in New York and Athens, which fill us with hope. I couldn't let it go without kind of circling back to Annette's point, questioning what the responsibility of the state is versus a fundraising initiative and the sustainability aspect of both. I think that for me, the new normal has to involve a critical analysis of government spending. If our governments, our elected governments, aren't spending on health and housing and programs that enhance human dignity, then they're not doing their job. And I think it's time that we question the billions of dollars spent on possibly ineffective law enforcement. We know it doesn't enhance security. We know it doesn't enhance sense of well-being. It's not improving health or HIV or Hep C. So I think that lies ahead for us. Ryan, in particular, huge thank you for breaking up your Friday night in Jakarta to join us. And particularly, we're really, really grateful to have lessons from Arus Pelangi and the LGBTQIA community in Jakarta. And to our other speakers who are enormously busy, Alison and Monica, thank you so much for taking time out of your days. One last point is that in addition to the fact this webinar, we'll post the YouTube clip in the coming days. And we'll be running I think a final webinar in the series on women harm and harm reduction on the 14th of July. So watch out for that one. Thank you very much, everyone.